All right, let's dive deep into hand and finger infections. It's something we see all the time, and it's going to be on the board, so we've got to be ready.
Definitely, and we'll cover everything from the common stuff like paranephlia and cellulitis to the really serious things like deep space infections, flexor tenosynovitis, and necrotizing fasciitis. Oh, and we'll hit on infections from bites, septic arthritis, bone infections, the weirder fungal and mycobacterial infections, and what to do about implants too.
Yeah, for those exams, and when you're actually practicing, knowing the usual suspects, the bugs and what makes some people more vulnerable, how to diagnose them, and the basics of using antibiotics and doing surgery, that's the key. And we point out those red flags you absolutely can't miss.
Let's start with the culprits. The most common one we see in hand infections is Staphylococcus aureus.
Yeah, Staph aureus.
And right behind that, you'll see a lot of Streptococcus species.
Right, strep. But if someone's immune system isn't working well, we have to think about other things, right?
Absolutely. You might see gram-negative anaerobes or other unusual bacteria in those folks.
So what do we do?
Cultures, cultures, cultures. It's crucial to get those cultures before you start any antibiotics. And while you're taking those samples, be super careful with your technique, sterile everything, request aerobic, anaerobic, mycobacterial, and fungal cultures. That way we can really target the treatment.
And speaking of bacteria, we have to talk about MRSA.
Yep, methicillin-resistant Staphylococcus aureus.
It's everywhere, right? So we need to be ready with the right antibiotics even before the culture results come back.
Exactly. And some of the antibiotics that work well against MRSA are clindamycin, doxycycline, and trimethoprim sulfamethoxazole. It's good to know those, and of course, always double-check your local guidelines.
And don't forget about those less common infections, the fungal and mycobacterial ones.
Right, especially in those cases that just drag on and aren't responding to the usual antibiotics.
Yeah, those chronic ones, we need a whole different approach.
Now, when you're getting those cultures, try not to go through really red or inflamed skin if you can help it.
Why is that?
You don't want to contaminate a deeper, sterile area with bacteria from the surface. Could really mess up your results.
Good point. So now, who is more likely to get these infections and who's going to have a rougher time with them? Diabetes is a big one, right?
Huge, it's everywhere, and you wouldn't believe how many patients with hand infections turn out to have undiagnosed diabetes. It's a setup for deep space infections, amputations, and even necrotizing fasciitis.
Wow, that's serious. Why are people with diabetes so much more at risk?
High blood sugar throws a wrench in the works, you see. It messes with how neutrophils work. These are your first line of defense against bacteria. And high sugar also makes bacteria grow like crazy. It's like giving them a feast.
So their defenses are down, and then what?
And then, because of neuropathy, they may not even feel those little cuts and injuries that let the bacteria in, so they come in late when the infection's really taken hold. It's a double whammy.
Makes sense. So what happens with their immune system?
Basically, their white blood cells don't respond the way they should. They're slower to get to where they need to be. They don't gobble up the bacteria as well, and they're less effective at killing the bacteria once they've got them.
And if they have kidney problems on top of diabetes?
It's even worse. The risk of amputation goes way up. It's a tough situation.
Besides diabetes, what else raises the alarm bells?
Anything that suppresses the immune system. So think HIV/AIDS, serious chronic illnesses, organ transplant patients, people in autoimmune disorders, alcohol and drug abuse, malnutrition, renal failure. These all make it harder to fight infections.
Right, makes sense. And what about someone's job or their habits? Can that make a difference?
Definitely. Dental professionals are more prone to herpetic whitlow because they work with saliva, and people who work with their hands in water all the time, like dishwashers or who bite their nails, are more likely to get chronic paronychia. So asking about their work and their habits is really helpful.
Okay, so we know who to watch out for, and we know the bad guys. Now, how do we figure out what we're dealing with?
Taking a good history is the first step. Almost always there's some little injury, a puncture wound, a cut, something that breaks the skill.
Right, people usually remember those.
Ask about any chronic diseases, especially diabetes, and make sure they're up to date on their tetanus shot.
And what about the physical exam? What are we looking for?
Check the whole arm, not just the hand. Look for any discoloration, swelling, pus, or those red streaks that mean the infection is spreading through the lymph system. Feel for swollen lymph nodes and any temperature difference between the sides.
So compare both sides. Always.
Always. Don't forget imaging, too.
Right, x-rays. Right.
X-rays are your first step. They can show if there's something stuck in there like a piece of metal or glass, and they can give you clues about bone infection or gas in the tissues.
Gas in the tissues. That sounds bad.
It can be a sign of a really serious infection like necrotizing fasciitis or gas gangrene. Ultrasound is good for finding fluid collections near the surface. CT and bone scans are helpful in certain cases. And MRI with contrast, that's the gold standard for pinpointing those deep accesses.
So once we've got the whole picture, how do we approach surgery for these infections?
If you need a tourniquet, make sure you drain the blood out of the arm first, just by holding it up. We don't want to squeeze bacteria into the bloodstream with a tight wrap, and when you cut to drain the infection, make those incisions big enough.
Why is that?
You need to get all that push out, and sometimes you have to extend the incision to get it all.
I see. And any special techniques for where those incisions go?
Yeah. Avoid cutting lengthwise right across the lines where the hand bends.
Why?
You don't want a scar that's going to pull tight and restrict movement. And be careful around the nerves, blood vessels, and tendons. You want to get rid of all the dead tissue. That's crucial.
And what about cultures?
Even if you got cultures before surgery, get more from the infected area once it's in there. You need to know exactly what you're dealing with.
Right, so we can tailor the antibiotics?
Exactly. And make sure to irrigate that wound really well. A lot of sterile saline, let it flow through. Usually we'll leave the wound open and pack it with gauze, keep it moist, then a loose bandage and a splint, and get that hand moving again as soon as it's safe. That helps prevent stiffness.
Okay, let's talk specifics. What about cellulitis?
So cellulitis is when the skin and the tissues under the skin are inflamed. Usually it's from some small injury to the skin, and most often it's caused by Staph aureus or group A strep.
And how do we know it's cellulitis?
You'll see redness, swelling, pain, warmth, but you won't feel a pocket of pus under the skin.
And how do we treat it?
Since MRSA is so common, we often start with intravenous vancomycin, especially if it's a bad infection or the person has other health problems. We might admit them to the hospital depending on how sick they are, what other conditions they have, and if we think they'll be able to manage their treatment at home. Diabetic patients and those with lymphangitis infections spreading along the lymph vessels, they usually need IV antibiotics.
How do we know if the treatment is working?
You can draw around the edge of the redness with a marker and write the date and time. If it starts shrinking from that line, you know it's getting better. But if it's not getting better or it's getting worse, you might need to change the antibiotics and think about whether there's an abscess hiding under there that needs to be drained. Warm soaks, keeping the hand up, and a splint for comfort can also help.
Got it. Now, what about acute paronychia?
So that's an infection around the nail, and often there's an abscess. It's the most common hand infection we see. It usually starts with something like biting your nails or a rough manicure. Staph aureus is usually the culprit, but sometimes anaerobes are involved too. Patients have pain, redness, and swelling along the nail fold, and you might see some pus draining out.
How do we manage that?
Early on, warm soaks, antibiotics that cover MRSA, and resting the hand can do the trick. But if there's a definite access, you've got to drain it. You make a small cut next to the nail fold, away from the nail bed, and take a culture of the pus. You can put in a small wick to keep it draining. And they'll usually need antibiotics by mouth for 5 to 7 days. If that doesn't work, you might need to give them IV antibiotics. Warm soaks several times a day can help with healing. And if there's pus trapped under the nail itself, you might need to remove part or all of the nail. Packing the area can prevent it from closing too soon.
What about chronic paronychia?
Chronic paronychia is different. It's usually a fungal infection, most commonly Candida albicans. You see it a lot in diabetics and people whose hands are wet all the time. It looks like a hardened red area around the base of the nail, and you might see this whitish discharge.
How do we treat that?
We usually start with antifungals creams or ointments, but if that doesn't work, we might have to do a little surgery called an eponychial marsupialization.
Sounds complicated. What's that?
It's not too bad. We remove a crescent-shaped piece of skin from around the nail, clear out any unhealthy tissue, and let it heal on its own.
Okay, so what about felons?
A felon is an infection of the fingertip, the pulp of the finger. Usually it's from a puncture wound, and again, Staph aureus is often the cause. But in people with weaker immune systems, gram-negative bacteria can be involved.
What do patients complain about?
Their fingertip will be a really red, swollen, and super tender. The pain is usually throbbing and worse at night. Sometimes you can even feel that there's fluid under the skin.
And how do we treat a felon?
Well, if you can see or feel the most tender spot, you can make an incision right there. Otherwise, we usually make a cut along the side of the finger, either the pinky side for the index, middle, and ring fingers, or the thumb side for the thumb and pinky. You don't want to cut across the tip because that could affect blood flow. After you drain it, pack it loosely with gauze and start warm soaks and dressing changes in a day or two. Antibiotics will depend on the culture results. When you're draining it, make sure you break up any pockets of pus so it can all drain out, and stay away from the nerves and blood vessels.
Okay, so that's a felon. What about herpetic whitlow? It can look kind of similar, right?
Yeah, herpetic whitlow is a viral infection, usually caused by herpes simplex virus, and it usually goes away on its own in a couple of weeks. HSV-1 is more common in kids and healthcare workers, while HSV-2 is more common in adults. It's red and swollen, but usually not as tense as a felon. And the key is you'll see little clear blisters, which might run together.
So that helps us tell them apart. How do we treat herpetic whitlow?
The history of that tingling pain before the blisters appear, and the blisters themselves, that's usually enough to make the diagnosis. A Zank smear or viral culture can confirm it. Don't cut into those blisters unless you really think there's a bacterial infection on top of it.
Why not?
Cutting it can actually make it last longer and even cause complications.
Okay, I see.
We just keep it dry, covered with a loose bandage, and tell the patient not to touch it so it doesn't spread. Sometimes we use antiviral meds like acyclovir if it's a bad case or if the person's immune system is weak, and let them know it can come back.
So let's move on to those deeper hand infections, the ones that get into the spaces between the muscles and tendons.
Right, those are serious. You really need to know the anatomy of the hand, the thenar, mid-palmar, hypothenar, and peroneus spaces, to diagnose and treat these effectively. Infections can spread from one space to another, like in a horseshoe access, which connects the radial and ulnar bursae through peroneus space. These usually come from a puncture wound, and Staph aureus is the most common bug.
What are the signs?
They'll have pain, redness, and swelling in that part of the palm. Each space has its own little quirks, though. Like a thenar space infection can cause a lot of pain when they try to move their thumb, and you might see swelling on the back of the hand between the thumb and index finger.
What about the mid-palmar space?
That can make the palm look flat or even bulge out, and bending the ring and little fingers hurts.
How do we take care of these deep space infections?
We take them to the OR, use a tourniquet, and drain them. Placement of the incision is key. You want to get to the infection without damaging any important structures or causing a scar that will limit movement, especially in the web spaces between the fingers. Different approaches are used depending on which space is involved. After surgery, we elevate the hand, use a splint, and give IV antibiotics like vancomycin or clindamycin. If we think it's a mixed bag of bacteria, we might use broader spectrum antibiotics.
Now let's talk about flexor tenosynovitis. That's a scary one.
It is. It's an infection in the sheath that surrounds the tendons that bend the fingers.
Ouch. How do we know it's that?
There are 4 classic signs called Knuffel signs. The first and most reliable is pain when you try to straighten the finger passively. The finger will also be swollen all along its length, tender along the path of the tendon, and held slightly bent.
And the cause?
Most often, it's Staph aureus getting in through a puncture wound or spreading from an infection nearby, like a felon. Very rarely, it can spread through the bloodstream.
How do we treat it?
If it's caught very early, within 48 hours of symptoms starting, you might be able to get away with splinting, elevation, and IV antibiotics, but you have to watch them very closely. Most of the time, though, it's straight to the OR to drain it. We might make small incisions and flush the tendon sheath, or we might have to do a bigger open surgery to clean it out and pack it. It all depends on how bad the infection is. After surgery, we use a splint, elevation, IV antibiotics, and start hand therapy early and aggressively to prevent stiffness. Be aware that older patients, diabetics, people with circulation problems, kidney problems, signs of infection under the skin, poor blood flow to the finger, and infections with multiple types of bacteria, they all have a higher risk of complications.
Okay, let's move on to bites. Human bites can be nasty, can't they?
Yeah, they really can, especially those clenched fist injuries over the knuckles, the so-called fight bite. They're usually contaminated with a bunch of different bacteria from the mouth, like strep viridans, Staph aureus, Bacteroides, and Eikenella coliden's. It can look like a minor wound on the surface, but there can be a lot of damage underneath.
So what do we do?
You always have to examine the hand with the fingers bent to see the extent of the injury, and get an X-ray to check for broken bones, pieces of teeth, or air in the joint. Patients might not be totally honest about what happened, so keep that in mind.
All right, good point. And the treatment?
These usually need surgery to clean out the wound and remove any damaged tissue. We usually leave the wound open to heal from the inside out, or we close it later after a few days of observation and cleaning. We start with IV antibiotics that cover a broad range of bacteria, including anaerobic ones, followed by antibiotics by mouth, often amoxicillin clavulinate. Splinting, keeping the hand elevated, and starting hand therapy early are all important.
And what about animal bites, like dog and cat bites?
Dog bites are more common, but cat bites are more likely to get infected because their teeth are sharper and can deposit bacteria deep into the tissues.
And what are we worried about with animal bites?
Well, you need to know if the animal was vaccinated for rabies. Both dog and cat bites need antibiotics that cover Pasteurella multicida, along with staph and strap and anaerodes. Cat bites can also cause cat scratch disease, which is something to keep in mind.
So how do we treat them?
You got to clean those wounds really well. If you think a joint might be involved, you'll need to explore it surgically. We can often stitch up dog bites loosely after cleaning them up, but cat bites, we usually leave those open to heal on their own. The first line antibiotic is usually amoxicillin clavulinate because it covers Pasteurella.
Now, what about septic arthritis?
Septic arthritis is a bacterial infection inside a joint. It can destroy the cartilage really quickly and even spread to the bone. It can be tricky to get a sample of joint fluid from those small hand joints, and never try to get fluid through a red, inflamed area. If the fluid has more than 50,000 white blood cells per cubic millimeter, that's a big red flag.
What causes it?
Most often, it's from something puncturing the joint directly and introducing bacteria. Staph aureus is usually the culprit. It can also spread through the bloodstream, but that's less common in the hand. In kids, we think about strep and Haemophilus influenzae. In sexually active adults, especially if multiple joints are involved, gonococcal arthritis is a possibility.
And what does it look like?
The joint will be hot, swollen, red, and tender, and it'll hurt a lot even with just gentle movement. That pain that's worse than you'd expect based on the exam, that's a big clue. If there's no obvious puncture wound, you need to get a sample of joint fluid to confirm the diagnosis.
So how do we treat septic arthritis of the hand?
Surgery is the key. We need to clean out that infected joint, either using an arthroscope or with an open incision. We flush the joint with lots of fluid and remove any infected tissue. We also check the cartilage carefully and document any damage. Sometimes we'll leave the wound open with daily dressing changes, and sometimes we'll close it over a drain or a catheter that delivers antibiotics directly to the joint. They'll need IV antibiotics, splinting, and elevation, and we start hand therapy as soon as possible to keep that joint moving.
Necrotizing fasciitis. Just hearing the name sends chills down my spine.
I know, right? It's a scary one. It's a really aggressive infection that attacks the fascia, the connective tissue under the skin, and it can spread like wildfire. It can lead to amputation or even death. It's more common in people with diabetes, older folks, and anyone with a weakened immune system.
So what are we looking for?
The tricky thing is it can start out looking a lot like simple cellulitis, but then it progresses rapidly. The skin turns a dusty or bluish color, blisters start to form, and the person gets really sick really fast. Pain is usually out of proportion to how the skin looks. Later on, you might see numbness in the skin because the nerves are affected, and there's often a foul-smelling discharge that some people describe as dishwater pus.
Yikes. What about x-rays?
If you see gas in the soft tissues on X-ray, or if you can feel crackling under the skin, that points towards a clostridial infection, which is even more serious.
So what do we do?
This is an emergency. You need to remove all the dead tissues surgically as quickly as possible. That's the most important thing. We leave the wounds open and go back in as many times as needed to make sure we got it all. These patients need to be in the ICU because they can become very unstable very quickly. They need strong IV antibiotics, and we usually get an infectious disease specialist involved right away. Sometimes we use hyperbaric oxygen therapy, especially for clostridial infections. Often they'll need reconstructive surgery down the line, and it's a long road to recovery with lots of rehab.
And gas gangrene.
Luckily, it's pretty rare in the hand, but when it happens, it can be fatal very quickly. It's caused by bacteria called Clostridium, usually Clostridium perfringens. They produce toxins that destroy muscle, create gas in the tissues, and make people very sick very fast.
What are the signs?
It progresses much faster than necrotizing fasciitis, and the muscle dies quickly. The pain is severe. You might feel that crackling under the skin, and the person will be really sick. It can be hard to diagnose because Clostridium is tough to grow in the lab.
And how do we treat gas gangrene?
You got to recognize it fast and get them into surgery immediately. Remove all the infected tissue, leave the wounds open, and give them high-dose IV antibiotics that specifically target Clostridium. There's no time to waste.
Osteomyelitis. Tell me about bone infections in the hand.
They can happen when a soft tissue infection spreads to the bone after an open fracture where bacteria get in directly, or sometimes through the bloodstream. Staph and strep are the usual suspects. The area over the bone will be painful, swollen, and red, and sometimes there's a chronic draining wound that just won't heal. X-rays might not show much early on, but a bone scan or MRI is more sensitive, especially MRI with contrast.
What's the treatment?
They'll need a long course of antibiotics, usually 4 to 6 weeks or even longer, based on what we find in a bone biopsy and culture. Often we need to remove any dead bone surgically. Sometimes we'll need to do a bone graft or put in some hardware to stabilize the bone. Even with aggressive treatment, sometimes amputation can't be avoided.
Okay, so that's osteomyelitis. What about fungal and microbacterial infections and infections around implants?
Sure. Onychomycosis is a fungal nail infection, often caused by Trichophyton rubrum or Candida albicans. The nail will be thick, discolored, and crumbly. You need a fungal culture to confirm the diagnosis. For Trichophyton rubrum, we usually use oral terbinafine. Candida might respond to topical or oral antifungals. Removing the nail can sometimes help the oral meds work faster. Sporotrichosis is another fungal infection with time caused by Sporothrix schinki, which lives on plants. It gets in through a puncture wound, usually from a thorn or something like that. You'll see a nodule that turns into an ulcer, and then the infection spreads along the lymph vessels, forming more nodules under the skin. We diagnose it with a fungal culture, and the treatment is usually oral itraconazole or fluconazole for a few months. Atypical mycobacterial infections, often caused by Mycobacterium marium, which is found in water, will set as slow-healing skin or soft tissue infections that can form granulomas. You need a special culture to diagnose those. Treatment involves surgery to remove the infected tissue and a long course of specific antibiotics. And infections around prosthetic joints, those are a big problem. We often have to remove the implant, clean everything out really well, give them antibiotics, and sometimes do a staged reimplantation later on.
So to sum up, remember that Staph aureus and MRSA are the most common culprits in hand infections. Diabetes is a huge risk factor for complications. You have to be able to recognize the signs of flexor tenosynovitis and the early warning signs of necrotizing fasciitis. Know the bacteria that commonly cause infections from human and animal bites. And remember that early and aggressive surgery is often the key to saving the hand and sometimes even the patient's life.
And one last thought, if you really understand these infections, how to diagnose them and how to treat them, and if you know the bacteria involved and the things that put people at risk, you'll be well on your way to getting good results for your patients and preventing serious complications. Keep studying, focus on those critical decision points, and you'll do great.
Awesome. Thanks for taking the time.
My pleasure. Always happy to talk hand infections.
To our listeners, thanks for tuning into this deep dive, and we'll see you next time.
See you then.